Okay, so everybody's here, right? Okay, 57 of you are here. Okay, let me start the class. So today we are going to start a new topic. We are going to start cardiovascular system. So I'll be starting congenital heart disease. Now, congenital heart disease is a big chapter. So we won't be finishing it. We'll be finishing it in 3 classes. Okay. So we will be talking about fetal circulation, how to diagnose a baby with congenital heart disease, and we'll talk about some acyanotic heart disease and some cyanotic heart disease. Now, this is basically a revision from your embryology class. So we will be talking about fetal circulation first. Okay. So fetal circulations, you embryology ma parisakeko cha हैन? Okay, so fetal circulation is what happens in fetal circulation is, so you have fetal circulation and you have neonatal circulation. So fetal circulation occurs before birth, and during birth there is a transition and it goes into the neonatal circulation. Now fetal circulation occur in a serial conduit. So it is all the circulation are connected. So it occurs in a serial conduit, okay? Whereas in case of neonatal or adult circulation, it occurs in parallel conduit. So you have pulmonary circulation and systemic circulation separately. Whereas in fetal circulation, everything is connected. So what happens in fetal circulation? Baby receive blood from the placenta via the umbilical vein. So it will receive via the umbilical vein. It goes to from ductus venosus, it goes into the inferior vena cava. And from inferior vena cava, what happens is, it won't get mixed in the right atrium. A little bit of mixing will be there, but these will somehow, these oxygenated blood will be diverted directly into the left atrium, okay, via foramen ovale. So what happens in right atrium? So ductus venosus, inferior vena cava, then it goes into the right atrium, and from right atrium, there is a crista dividens. So that crista dividens will diverse the blood from the right atrium to the left atrium. From left atrium, it will go into the left ventricle, and from left ventricle, it will go into the aorta, and from aorta, the head and the neck will receive relatively oxygenated blood. Not a very oxygenated blood like in case of neonatal circulation, but relatively less deoxygenated blood. Okay, so this head and neck, subclavian artery, brachiocephalic neuropathy, this will receive, the head and neck will receive the blood. Now, what happens again in the right atrium is some amount of blood is mixed in the right atrium, because deoxygenated blood will be coming from the superior vena cava and inferior vena cava. And these mixing of the blood, when these mixed deoxygenated blood will go into the right ventricle. From right ventricle, it will go through the pulmonary trunk. A very less amount of blood will go into the lungs because lungs are not inflated. And that less amount of the blood is again returned to the left ventricle via pulmonary vein, left atrium. And what happens from the pulmonary trunk is the majority of the blood. Yes, is there any problem? Majority of the blood will go from the pulmonary trunk directly to the aorta, descending aorta, via this one, ductus arteriosus. Okay, so what happens is, this occurs distal to the left subclavian artery. What happens is, descending aorta will get the deoxygenated blood, and descending aorta will give the blood to the lower limbs. And from there, through the pulmonary arteries, it will again go into the placenta. This is what fetal circulation is about. You need to be very clear about fetal circulation, because most of the congenital heart defect are because of persistence of the fetal circulation. Okay, so I'm going to review one more time. This is the schematic diagram. So we'll be talking about this one. You can refer to this one as well. So placenta bata ke huncha first ma? Here is the placenta. From placenta, blood will enter via the umbilical vein. And from umbilical vein, there is a ductus venosus. So ductus venosus will go to the inferior vena cava. From inferior vena cava, the blood will go into the right atrium. And from there, it will go into the left atrium via the foramen ovale. Left atrium ma ke huncha, then the blood will go into the left ventricle. And from left ventricle, it will go into the arc of aorta, and the head and neck will receive the blood. Now, certain amount of blood will be mixed in the right atrium from the deoxygenated blood received from the superior and inferior vena cava, and these blood will come into the right ventricle. From right ventricle, what will happen? It will go into the pulmonary trunk. Since lungs are not inflated, there is very less amount of blood shunted to the lungs. So majority of blood comes answer. It will go into the descending aorta via a ductus arteriosus, and ductus arteriosus connection is usually distal to the left subclavian artery. So what will happen? Deoxygenated blood will then flow through the descending aorta and supply the organ of the lower limbs, and then this deoxygenated blood will again go to the placenta for via the umbilical arteries. So basically, head and neck will be receiving relatively more oxygenated blood, and lower limbs will be receiving a little bit of more deoxygenated blood. Okay, so this is about fetal circulation. So what is the difference in fetal circulation? Main organ of gaseous exchange is placenta, not the lungs. Okay, so what happens? Umbilical vein but is answer, and there are certain entity that is very much related with the fetal circulation. They should not be present in the neonatal circulation. Number one is umbilical vein. Then it goes through ductus venosus but inferior vena cava but a right atrium but a foramen ovale. So what are the points that are typically present in the new fetal circulation? So these are the points. One is ductus venosus, then after there is foramen ovale. From foramen ovale, it will go into left atrium, then through left ventricle, aorta, and systemic circulation. So some blood will go from right atrium to right ventricle, then from the pulmonary trunk. This portion is relatively very less. Pulmonary trunk but the lungs ma dere kam blood chance, because lungs is not inflated. Most of the blood will go into the aorta via the ductus arteriosus. So these three entities is very important in fetal circulation. Usually congenital heart defects are because of persistence of these entity. So ductus venosus, foramen ovale, and ductus arteriosus. Okay, so everybody clear about fetal circulation? Everybody clear about fetal circulation? Speak up.
Yes, ma'am.
Yes, ma'am.
Okay. So now this is again what happens during birth. So how is fetal circulation changed into neonatal circulation? Number one, when there is fetal circulation boy, when the baby is born, what happens? You clamp the cord. Okay, so cord clamping boy, what will happen? Or there is baby will take the first few breaths. So these two things will occur. Let's talk about this one. The baby will take first few breaths, gasping breathlines. What will happen? There is a decrease in pulmonary vascular resistance. So lungs are first, it will be closed, it will be filled with fluid. So the pressure is very high. So when the baby starts to take breath, the pressure, the lung alveoli will open up, and there is decrease in the pulmonary vascular pressure. Pulmonary vascular pressure decrease, there is increase in the pulmonary blood flow. Whenever there is increase in the pulmonary blood flow, more amount of blood will go into the lungs, and from lungs, it will return back via the pulmonary vein to the left atrium. Okay, so left atrium ko feeling pressure will increase. And after that, when left atrium ko pressure becomes more than right atrium ko pressure, what is happened? There is a functional closure of foramen of ovale. Number one, first tunicula uvio. So when the baby takes breath, there is decrease in the pulmonary vascular resistance because alveoli will open up. And when there is decrease in the pulmonary vascular resistance, pulmonary blood flow will increase. When the pulmonary blood flow will increase, more blood will enter into the lungs, and from lungs, it will return back to left atrium. So left atrium pressure will increase more than the right atrium, and that causes closure of the foramen ovale. Number one, uvio. Okay. Number two, what happens? Because there is decrease in the pulmonary vascular resistance, there is reversal in the ductus arteriosus. Reversal in the ductus arteriosus kina huncha? Now the pulmonary trunk pressure is also high. Okay, so pulmonary trunk pressure high bhayepachi, instead of the blood flowing from the pulmonary trunk to the arc of aorta, it will then go to the lungs. So there is increase in the pulmonary blood flow that also causes increased left atrial pressure, and there is a functional closure of foramen ovale. Number 2, euboea. Number 3, when you have cord clamping, भइसकेपछि what happens? Your placental circulation will eliminate it. When there is a placental circulation eliminate purpose, what happens? There is a fall in prostaglandins. So decreased prostaglandin, it causes constriction of the ductus arteriosus, and constriction of ductus arteriosus will then revert it to the, will then change it into the neonatal circulation. So another one, reversal of ductus arteriosus also causes rise in partial pressure of oxygen, because all of the blood is being shunted to the pulmonary blood flow. The baby is taking breath. Okay, so PaO2 rise. PaO2 rise hune bittikai ductus arteriosus will constrict. Okay, when there is rise in partial pressure of oxygen and fall in prostaglandin level, ductus arteriosus will constrict, and that will convert it into neonatal circulation. We'll review it one more time. So what happens? The baby will gasp and take few breaths. So there is decrease in the pulmonary vascular resistance. And then there is increase in the pulmonary blood flow. Vascular resistance kam hune bittikai pulmonary blood flow increase huncha. So more blood will flow into the lungs, and more blood will return back into the left atrium. So left atrium pressure will increase. That causes functional closure of foramen ovale. Number 1. Number 2, when you have cord clamping, placenta circulation will be eliminated. There is fall in prostaglandin level. Prostaglandin level fall bhayeपछि it causes constriction of ductus arteriosus. Okay. Number 3, when there is decrease in the pulmonary vascular resistance, there is a reversal of shunt in the ductus arteriosus, because pulmonary trunk pressure will also increase. So ductus arteriosus बाट blood कहाँ जान्छ? It will go into the lungs rather than going into the aorta. So there is increased pulmonary blood flow, increased left atrium pressure, functional closure of foramen ovale. When there is increased blood flow into the lungs, there is rise in the partial pressure of oxygen. So rise in the partial pressure of oxygen causes ductus arteriosus constriction, so which causes neonatal circulation. Okay, so these are the 3 things that occurs which converts fetal circulation into neonatal circulation. So this first diagram is the fetal circulation, and this is the neonatal circulation, or our normal circulation. So fetal circulation, it occurs in the series. Neonatal circulation, what happens? The right side is going on parallel with the left side. So pulmonary circulation will occur separately, and your systemic circulation will occur separately. So what happens? Ductus venosus close huncha, foramen ovale. Ductus, so kaka near close huncha? Ductus venosus. So this is close. Foramen ovale is close, and ductus arteriosus is close. Okay, so you have ligamentum arteriosus for ductus arteriosus. For ductus arteriosus will change into ligamentum arteriosus. Ductus venosum will change into ligamentum teres hepatis, okay, and foramen ovale will be closed foramen ovale. So you have closed foramen ovale, okay. So in case of neonatal circulation, what will happen? The right atrium, inferior vena cava, and superior vena cava and inferior vena cava where the blood जान्छ, it will go into the right ventricle. From right ventricle, it will go into the pulmonary trunk, then it will go into the lungs, and from lungs, it will return back to the left atrium. From left atrium, it will go to the left ventricle, and from left ventricle, it will go to the aorta and distribute to the different organ. So this is how there is a transition between fetal circulation and post-neonatal circulation. Whenever there is problem during this transition, you have a structural defect known as congenital heart disease. Okay? यतिसम्म clear छ कि छैन? Any question?
Ma'am, ductus venosus को चाहिँ closure कसरी हुन्छ mechanism?
Ductus venosus को because your umbilical, this is clamped, right? So you clamp bhayeपछि what will happen when this is clamped? You have you cord clamp bhayeपछि you have no blood flow flowing from the umbilical vein into the inferior vena cava. So this will degenerate and convert into ligamentum teres hepatis. Okay? बुझ्यो?
हस् म्याम बुझेँ
So just umbilical vein बाट circulation बन्द भइसकेपछि that what happens is this will be obliterated. So this will fall off and they will convert into ligamentum teres hepatis. Clear? Clear?
यस म्याम
Fetal circulation, no more questions. Okay, so let's go. No more questions, right? Okay, so now let us go to the next slide. So let's go to our main topic, which is congenital heart disease. So what is congenital heart disease? So it is anomalies arising as a result of a defect in the structure or function of the heart and great vessels. Okay, so there is defect in the structure and function of the heart and great vessels, which is present at birth. So incidences, almost 1 to 3% of total birth will have some form of congenital heart disease. So it is pretty common. Now, according to the heart defect classification, you can have cyanotic heart disease and acyanotic heart disease. We will be talking about each one of them in detail later. So, cyanotic heart disease, cyanotic heart disease, baby will be blue. Okay, so there is decreased pulmonary blood flow and there is right to left shunt, right side of heart but left majana saksa. Okay, so what are the important cyanotic heart disease? Tetralogy of Fallot, tricuspid atresia, other univentricular heart defect, transposition of great arteries, total anomalous pulmonary venous return. These are some of the examples of cyanotic heart disease. The basic principle in cyanotic heart disease is there is right to left shunt. So right heart but left heart ma jansa. So deoxygenated blood will go from right to left and then deoxygenated blood will go to the systemic circulation. So that is the basic principle of cyanotic heart disease. Now, acyanotic heart disease ko basic principle is there is left to right shunt. Left but right ma gaisakepachi what happens? Left side of heart but right side of heart ma gayo bhane there is increased blood flow to the lungs and so baby will present with pulmonary edema. Okay, so acyanotic heart disease ko examples ma ventricular septal defect, atrial septal defect, AV septal defect, patent ductus arteriosus, aortic stenosis, pulmonary valvular stenosis, and coarctation of aorta. These are some examples of acyanotic heart disease. So if you have to remember the basic principle, cyanotic heart disease ma blood ka flow unsa right side of heart but left side of heart ma jansa. So what will happen? The baby will receive deoxygenated blood. Acyanotic heart disease ma ke hunsa? The blood will flow from the left side of heart to right side of heart. So what will happen? There is increased blood flow to the pulmonary circulation increase unsa, lungs ma blood flow body unsa. So lungs ma blood flow body hune bittike, what is the presentation? The baby will present with pulmonary edema features. Okay, so clear about this one?
Yes, ma'am.
Okay, so now how do you approach a child with a baby with congenital heart disease? This is the basic approach. Okay, so how does a baby present? If a baby has congenital heart disease, baby can present with any of these things. Okay, so this is I'm not dividing into cyanotic and acyanotic as yet. So baby congenital heart disease is present. Number one is if the baby has cyanotic heart disease, they will present with cyanosis. Okay, central as well as peripheral. So central cyanosis is must. So another very important presentation is difficulty feeding and poor growth. Most of the time, the baby will present with difficulty feeding, khana garo huncha. Ekchin khancha, then after what happens? Breastfeeding gardaheri, the baby will get tired and then baby will just leave and again will try to feed, irritable huncha because the child is hungry, will try to feed again because feeding gardaheri ke garcha, exertion huncha and then again the baby will have dyspnea and the baby will leave. Okay, so when there is difficulty feeding, most of the time weight gain ramro hudaina. So any baby with poor weight gain, you always look out for congenital heart disease. Okay, that is very important. The first factors that usually a newborn present or usually a child infant present with congenital heart disease is poor growth or poor weight gain. Okay, so difficulty breathing on exertion, our newborn exertion baneko during crying, during breastfeeding, what will happen? The respiratory rate will start to increase. So respiratory distress, one of the differential diagnoses is congenital heart disease. Another common presentation is frequent chest infection, especially in case of left to right shunt. When pulmonary lung is receiving lots of blood, what will happen? The baby will, pulmonary edema features, the baby can have frequent chest infection. The normal chest ma babies are normal ma bronchiolitis less severe hunsa. Congenital heart disease babies are bronchiolitis will have more severe presentation. Okay, so another common presentation is frequent chest infection. They will have repeated pneumonias, repeated bronchiolitis because of increased pulmonary blood flow. Another one is some babies with syndromes like Down syndrome, Turner syndrome, Noonan syndromes are associated with congenital heart disease. Most common congenital heart disease in Down syndrome is atrioventricular septal defect or endocardial cushion defect. Turner syndrome ma coarctation of aorta huna sakcha. Noonan syndrome ma pulmonary stenosis huna sakcha. Okay, so these syndromes are associated with many congenital heart defects. And when you see a typical syndromic feces, like if you have a Down syndrome ko typical faces dekhyo bhane, you always do a echo to rule out congenital heart disease. Turner syndrome ma pani you do a echo to rule out coarctation. Okay, and babies with cyanotic congenital heart disease may sometimes present with cyanotic spell. Cyanotic cell vanego, they are blue, but sometimes will turn very blue and can have anoxic, hypoxic attacks. Okay, this cyanotic spell will talk in detail in the cyanotic congenital heart disease. Okay, so these are the different presentation that occurs in the babies with congenital heart disease. So the baby will present, if you even forget everything, remember, if a baby has a poor weight gain, you always walk off for congenital heart disease. Okay, so how will they present? They may present with cyanosis. They may present with difficulty feeding and poor growth. They may present with difficulty breathing on exertion. On exertion, baniko cry garepachi, feeding garepachi, tachypnea huna sakcha. They can have frequent chest infection. They can have cyanotic spells. Or if you see any syndromic babies like Down syndrome, Turner syndrome, Noonan syndrome, always do an echocardiography to rule out congenital heart disease, because these syndromes are associated with congenital heart disease. Now, there is a criteria known as NADA's criteria. Okay, so NADA's criteria is a criteria which usually we do it when to suspect if the child has heart disease or not. Okay, Aru criteria majaste. This is the criteria to suggest for the presence of heart disease. We use it as major criteria, the minor criteria unsa. Major criteria mein ke cha? Number 1, systolic murmur, grade 3 or more intensity. Number 2, diastolic murmur. Number 3, cyanosis. Number 4, features of congestive cardiac failure or features of heart failure. So if the baby has any of these criteria, that falls into major criteria. Number 1 is there is systolic murmur of grade 3 or more. Diastolic murmur, if diastolic murmur is there, regardless of the grade, that is major criteria. If the baby has central cyanosis, that is major criteria. If a baby has features of heart failure like hepatomegaly cha, chest ma purai crepitation cha, JVP haru raised cha bhane, that is the major criteria. Now minor criteria ma, if the baby has systolic murmur of grade 2 intensity, if there is an abnormal second heart sound, if there is abnormal ECG, if there is abnormal chest X-ray, and if there is an abnormal blood pressure, high blood pressure or low blood pressure, that will be considered as minor criteria. Okay, so systolic murmur, grade 2, abnormal second heart sound, ECG, chest X-ray, and blood pressure will come as minor criteria. Okay, so if there is one major criteria or 2 minor criteria, then it suggests there is a presence of heart disease. Then we need a detailed workup for heart disease. Okay, 1 major criteria or duita minor. Duita minor bhapani, you need to work up for congenital heart disease. If there is 1 major criteria present, then you need to go for a workup for congenital heart disease. You need a detailed workup with echocardiography, cardiac catheterization, whatever. Okay. So this is NADA's criteria. This is very important to diagnose congenital heart disease in a child. Now, what are the investigation modalities to diagnose congenital heart disease? There are many investigation modalities. You may need all your blood counts and all those, but these investigations are specific for diagnosing the congenital heart disease. Other investigations we need to do to diagnose heart failure, right? So this is for diagnosing structural congenital heart disease. So the three things that we do regularly are ECG, chest X-ray, and echocardiography. Okay, you need ECG, chest X-ray, and echocardiography. And when you diagnose this from these three investigations, to confirm the diagnosis and to do detailed investigation, we go for cardiac MRI, cardiac CT scan, or diagnostic cardiac catheterization. So, एकैचोटि cardiac MRI, CT scan मा जाने हैन. First basic investigation first. Whenever you suspect NADA's criteria garyo, clinical features ma congenital heart disease jasto लाग्यो भने, we do these three investigation first: ECG, chest X-ray, and echocardiography. From there, when you diagnose a congenital heart disease, and if you have to go to interventions, diagnostic intervention or therapeutic intervention garnu paryo भने, and to confirm the structural defects, then we go for these advanced investigation, which is cardiac MRI, cardiac CT scan, and diagnostic cardiac catheterization. For upcoming topics, we will be focusing mostly on ECG, chest X-ray, and echocardiography. Okay, so now let's talk about acyanotic heart disease. Acyanotic heart disease ko basic criteria ke थियो? There is left to right shunt. So blood will flow from the left side of the heart to right side of the heart. Right side of the heart ma जाने बित्तिकै pulmonary trunk बाट pulmonary lungs ma धेरै blood flow हुन्छ. When the lungs is receiving a large amount of blood, there will be features of pulmonary edema. So respiratory distress ma present गर्छ. Okay, the basic principle of acyanotic congenital heart disease is left to right shunt. So we'll talk about individual congenital heart disease. We'll be talking about atrial septal defect, ventricular septal defect, patent ductus arteriosus, and coarctation of aorta. 4 important acyanotic congenital heart disease. Now let's talk about atrial septal defect. So what is atrial septal defect? Atrial septal defect is abnormal opening in the atrial septum. So there is an abnormal opening in the atrial septum. So right atrium and left atrium could beach ma, there is a abnormal connection. So this is atrial septal defect. So it occurs in 4 to 10% of congenital heart disease. So what happens? There are different types of atrial septal defect. Atrial septal defect, if you remember your embryology, ostium primum huncha, then there is ostium secundum huncha, atrial septal defect ma. So ostium primer bhaneko muni bata aउँछ. So this is right atrium. So this is left atrium. So this is right ventricle. This is left ventricle. And this is tricuspid valve. This is mitral valve. Tricuspid valve. And this is mitral valve. So what happens? Right atrium to left atrium ma, if the atrial septal defect is over the ostium primum ma cha bhane, it is known as ostium primum. Okay, it is over the septum primum ma cha bhane, it is known as ostium primum. So if it is over the ostium secundum, septum secundum, it is known as ostium secundum. So if it is over the coronary sinus bhaneko coronary artery nira cha bhane, it is known as coronary, AST may be coronary sinus defect. So it is near the coronary artery. Okay. So if it is near the opening of the superior vena cava, inferior vena cava opening nira cha bhane, it is known as sinus venosus. So these are the different types of AST. If it is near the ostium primum, that is towards the ostium primum, is very bad because it is towards the tricuspid valve or mitral valve ko nira huncha. That is why ostium primum will not close spontaneously. You will require a surgical intervention, ostium primum. So you remember your embryology, right? The septum secundum and septum primum. Do you remember your embryology?
Yes,
no confusion, sir? Yes, okay.
ma'am.
Septum primum ma AST7, that is known as ostium primum. Septum secundum AST7, that is known as ostium secundum. If it is near the superior vena cava or inferior vena cava, it is known as sinus venosus. If it is near the coronary artery, it is known as coronary sinus. These are different type of AST. You need to know the different type of AST. Why? Because it depends upon the prognosis. If it is ostium secundum, that is very good. Best prognosis ostium secundum ko huncha. Usually size सानो छ भने spontaneously close huncha. If it is sinus venosus, ostium primum or coronary sinus, usually surgical intervention may be required. Okay, so you need to know the types to know the prognosis of the disease. Now hemodynamics. Okay, so remember this picture very carefully. All of the disease, all of the septal defects, all of the congenital heart disease, we will be referring to this one. Okay, so what happens? Simple, yeah, physiology. Blood will enter from superior vena cava and inferior vena cava into the right atrium. Right atrium bata blood ka jancha right ventricle. Right ventricle bata blood ka jancha pulmonary artery. Pulmonary artery bata blood ka auncha pulmonary vein bata left atrium ma. Left atrium bata blood ka auncha left ventricle, and then it will go into the aorta. This is your normal circulation. So what happens when there is an AST? Okay, you should know that right atrium ko pressure, left atrium ko pressure. So can anyone tell me what is the right atrium ko pressure? Which one has higher pressure, right atrium or left atrium normally? Anyone? Which one has high pressure, right atrium or left atrium?
Left atrium.
Left atrium, very good. Left ventricle has higher pressure than
higher.
right ventricle. Okay, so what happens over here? Left atrium pressure will be high. So whenever there is a defect in the atrial septal defect, defect, what will happen to the blood? Because left atrium pressure will be more than right atrium. High pressure but a low pressure blood flow. Okay, so blood will enter. So right atrium but right ventricle and left atrium blood ka jancha ta. Some part will go to left ventricle and some part will be diverted back to the right atrium. Okay, so there is increased blood flow from the right atrium to right ventricle. Right ventricle will receive more amount of blood. And if right ventricle will receive more amount of blood, what will happen? The pulmonary artery will receive more amount of blood and lungs will be receiving more amount of blood. Okay, this is what happens. So this is what happens in the atrial septal defect. Okay, is my confusion boy? So right atrium blood ounce, superior vena cava bata right atrium ounce, then it will go into right ventricle, then it will go to the pulmonary artery, then it will come back to the left atrium, and then it will go to left ventricular aorta. But some amount of the blood will be diverted from this defect, some amount of the blood will divert it into the back into the right atrium. So more amount of blood will enter into the right ventricle and more amount of blood will enter into the lungs. Okay, so there is left, this is what left to right shunting means. So there is left to right shunting. So there is increased pulmonary blood flow, which will lead to pulmonary hypertension. And because right ventricle is receiving more amount of blood, there will be right ventricular hypertrophy. So this is what happens in the atrial septal defect. Now atrial septal defect ma alikati less huncha kinabhane right atrium र left atrium. Right atrium ko pressure will be around 0 to 6 millimeter of mercury. Left atrium ko pressure will be around 8 to 10 millimeter of mercury. So there is not much pressure difference, right? So there is not much pressure difference. That is why lots of blood won't be diverted from the left atrium to right atrium. Okay, significant blood hudaina. But pulmonary hypertension and right ventricular hypertrophy is not that significant in case of AST. When we talked about VST, now that becomes very much significant. Okay, and then lots of complication occurs. But even though if it is not significant, there is a blood diverted from left atrium to right atrium. Pulmonary blood flow will increase, which will lead to some amount of pulmonary hypertension and some amount of right ventricular hypertrophy. Any confusion in the hemodynamics? This will be same in all of the congenital heart defect. Aile confusion sa bhane bhani halne. Confusion sa?
No.
Okay. So how will the baby present then? Most of AST condition ma, most of the babies will be asymptomatic. Okay, small AST ma. And AST is sometimes diagnosed coincidentally. Okay, and sometimes ali thulo bhayeपछि diagnose गर्न सक्छ. they usually present with early fatigue. Early fatigue, why? Because there will be increased blood flow to the pulmonary lungs and there is pulmonary edema. So, alikati hinne exertion पछि they will have features of respiratory distress. Again, there will be feeding difficulty. If you have pulmonary edema, what will happen? You have exertion on dyspnea on exertion, and you can have early fatigue, features of feeding difficulty, and there is a growth hampered. So feeding difficulty, stunted growth. So these are the clinical presentation of atrial septal defect. Now, what happens to the clinically? Clinically, you have to know about first heart sound, second heart sound, shunt murmur, and flow murmur. So first heart sound, what will happen to first heart sound? First heart sound is usually normal. Okay, can anyone tell me what first heart sound ke liye form huncha?
Closure of
Yes, closure of
atrioventricular valve.
So mitral valve, tricuspid valve close huncha. Okay, so S1 will be normal because blood will be mitral valve, tricuspid valve blood flow is okay. So S1 will be normal. What is S2? Second heart sound ke liye form huncha?
A closure of the semicircular valve, that is aortic and pulmonary valve.
Yes, the closure of the aortic and pulmonary valve will cause second heart sound. Now there is increased blood flow in the pulmonary trunk. Okay, when there is increased blood flow in the pulmonary trunk, what happened here? P2 will be loud. Okay, and S2, if you remember your physiology, S2 is formed by two components, A2 and P2. Okay, and it will be split unsa variable. Inspiration or expiration ma A2 and P2 sound will be different. In case of ASD, what happens? Because there is increased blood flow through the pulmonary trunk, P2 will be accentuated. P2 will be loud and split will be fixed. That means it is not variable with respiration. Okay, so first heart sound will be normal in case of ASD. Second heart sound ma splitting fixed unsa, there is no variation with respiration, and P2 will be accentuated because there is increased blood flow through the pulmonary trunk. So this is P2, first heart sound or second heart sound boy. Now shunt murmur or flow murmur. Murmur bhaneko ke ho? It is an abnormal sound heard in the cardiovascular system. Heart ma abnormal sounds. Shunt murmur bhaneko, the murmur heard through the defect, that is shunt murmur. The murmur heard due to increased blood flow through the normal structure is the flow murmur. Okay, so this is shunt murmur and flow murmur. Shunt murmur ki huncha because left atrium and right atrium ko, can you rejoin?